What about for Asia? The SAPIEN valve. The SAPIEN valve became available in Asia in February 2009. And the core valve was commercially available in October 2009. And you can see that it took some years before we got a better device, the SAPIEN XT, which is NovaFlex, in August 2010. And then the SAPIEN 3 only became available in Asia in October 2015. And I believe that was in Japan, and Southeast Asia only got it in 2016. The competitor Evolut R became available in Asia in 2015 and the Pro in mid-2017. So this was the first patient that we performed in Asia using the very first generation SAPIEN valve, not even the XT, the SAPIEN. Performed very well actually, and patient, it was a very good success, and the patient actually, when I last knew, he was alive and well at 10 years. Of course, that's some years ago. At 10 years, he was about 87 years of age already. So this is what we had to work with in 2009. You can see now it looks very primitive. Still the same balloon expandable frame, bovine pericardial leaflets, but look at the sheath size, 22 French for the 23 mm valve and 24 French for the 26 mm valve. So as you can see, a lot of patients were not suitable for the transfemoral approach because the devices were too large. And at the time, way back in 2008, we already discussed how we should look at the trials and assess the results and outcomes of TAVI. And this actually came step by step, beginning with the inoperable patients, which is patients who cannot be operated or too high risk for operation, such that there's no point doing any surgery for them. And in this trial, the very early cohort B partner trial, you can see that if you did nothing, the patients would all be dead. 50% of them at 1 year. For those who underwent TAVI, you save about 20%, and the number needed to treat was only 5. If you look at it another way, if you did nothing, medical therapy, the patients lived about 11 months. If you did TAVI, they lived nearly 30 months, which is almost 3 times as long, which is, I think, a very good result for a group of patients who are not surgical candidates. And then we had the, so this was the result in 2010. And in 2011, we had this cohort A results coming out comparing TAVI versus surgery in high-risk patients. And you can see that at the end of 3 and then subsequently at 5 years, there was no clinical difference between the two treatments, either with all-cause mortality or all-cause mortality and stroke. And we also knew that this treatment would greatly evolve as the technologies improve, and better device design, and with increasing operator experience, the technology will become safer and allow a wider application to a patient population. And indeed, this was so, as we see that the valves from the Cribia Edwards became the SAPIEN and subsequent SAPIEN XT. The delivery system was improved. And I think in particular, the sheath size became much smaller. You can see the 22 French that we used at the beginning became the 18 French NovaFlex system for the SAPIEN XT. And this was used in the intermediate trial, randomizing patients to surgery versus TAVI. And you can see that this was the device at the beginning in cohort A and B, and now in the intermediate risk patients, it was a better or smaller profile device. And when we look at the results, again, at 1 and 2 years, there was no difference between surgery or TAVI. And again, also mortality and stroke. And in fact, there was a slight trend to a lower event rate with TAVI when you pull these two endpoints together. So, so TAVI using the SAPIEN XT, there was no difference. But in the transfemoral group, there was a slightly lower all-cause mortality and disabling stroke. And this was actually in 2016 when we got the results. Subsequently, the last group of patients, the low surgical risk, this came out in March of 2019. And you can see that the average age of the patients was only 73 years old. And this trial only randomized patients who were suitable for the transfemoral arm. There were no more transapical or alternate access groups against surgery. And this is now the SAPIEN 3. which is a better valve with an external skirt to reduce paravalvular leaks. The sheath size further reduced in size to 14 French for the smaller valve and the 16 French for the large 29 mm valve. So you can see at 1 and 2 years, as we know now, the primary endpoint of death, stroke, or hospitalization was strongly in favor of transcatheter valve. And mortality, a lower trend with TAVI, but not significantly so. But all stroke was also lower with TAVI. And again, if you pull all-cause stroke and death, then it is also superior with TAVI in the low-risk population. So using the SAPIEN 3 valve, we can conclude that in patients who are at low surgical risk, TAVI is superior at 1 and 2 years with the primary endpoint of all-cause death, stroke, or rehospitalization. And also it was superior if you just pull death or stroke alone. So this is where we are at since 2007 or 2002, since the first in human. The paper here in patients who cannot undergo surgery, to high-risk patients, to intermediate or medium-risk patients, and now to the low-risk patient population. And you can see the device evolution from the very crude Creevy Edwards to the SAPIEN valve, and then the results of the inoperable high-risk group, and then the XT valve for the intermediate risk group, and now the SAPIEN 3 results which were applied to the low-risk group. So because of this, FDA has since 2019 approved TAVI as an indication for low-risk patients. So we also have seen that many years ago that in bicuspid valves, of course, this is a very big topic in Asia with a big proportion of bicuspid patients in Vietnam, I understand, and also in China, that we can actually achieve a very circular expansion despite the valve not being symmetrical. So let me show you a case of a SAPIEN 3 in a patient with a sentinel cerebral protection. This is what we can achieve with the current device. 77-year-old female with breathlessness and exertion, severe aortic stenosis with AR. And bear in mind that the recent negative trial using this sentinel device was published in the New England Journal of Medicine, but there was a trend towards less disabling strokes. Maybe the trial was not big enough, or there were some issues with the way the trial was designed. But I think more important is that this sentinel device, I'm still hopeful that maybe we should not be looking just at stroke, but also neurocognitive function in patients undergoing TAVI. Nevertheless, let me show you the case. So this is a patient of mine. And here we are putting the filter, opening the filter in the innominate artery. And then subsequently, the second filter is then pushed open in the left carotid artery. So this is the SAPIEN 3 valve. And you can see that we rapidly pace the heart, and the deployment, as you can see, once we put it wherever we want, the valve barely moves, and it's very stable in almost all patients that I've done all these years. And you can see that with this valve, you get almost no paravalvular leak or trivial paravalvular leak in most cases. In fact, I think in my last 3 or 4 years, I've only had a couple of cases with residual mild paravalvular leaks, and those were in patients with very severe calcification in bicuspid valves. For most tricuspid valves, we get a zero or trivial paravalvular leaks. This valve is also suitable for valve-in-valve patients, and this is also now FDA and CMARC approved. And you can see that the SAPIEN valve can be very easily put into a degenerated or worn-out tissue valve. And we also had some experience with this, and the results were very good. In fact, there were no complications at 30 days or even at 1 year. Let me show you another case where we can use this SAPIEN 3 valve in another location with a degenerated bioprosthesis. This is a patient with the mitral valve. You can see multiple risk factors, and the valve has since degenerated with a severe mitral bioprosthetic stenosis. So this is how we do it. We come transseptal, and then we cross the interatrial septum, and we then deploy the TAVI valve across the degenerate mitral valve prosthesis. So this is the only valve that we can use on the market, which is versatile enough to be used in the aortic and now the mitral position. And this is the end result with a very good position. And we can see that the gradient dropped from 22 to 10 millimeter mercury with a very significant improvement in the pulmonary pressure for this patient. Another location that we can use this SAPIEN valve, this is a patient with a tricuspid valve involved, 64-year-old male, multiple surgeries done before, multiple valves, and then now with increasing breathlessness, abdominal and leg swelling due to severe or torrential TR. You can see that the previous valve has degenerated. It was just basically wide open TR, and the surgeons did not want to operate on him. So he came to us, and this is how we implanted the SAPIEN 3 valve into the tricuspid location. So you can see it's a very flexible system. We can easily maneuver the valve across that band. And here we are deploying. Note that initially the valve was not coaxial, but as we inflate, it auto centers and achieves a very nice position. So this is how it looks at 1 year. No more tricuspid regurgitation, and the abdominal swelling and lower limb swelling is all resolved. So what about the next generation? Now we're on SAPIEN 3. There is a SAPIEN 3 Ultra coming up. I think it's easier to use. We don't have to prep the valve in the body. I think it will be as accurate to implant. Maybe good, even better sealing to reduce paravalvular leaks. The usual low pacemaker rate we know that have been associated with Edwards devices. And of course, easy access to coronary arteries, which is a big concern now that we are doing heavy in younger and younger patients. Hopefully, we will get the SAPIEN 3 Ultra next year, mid-year. So this is how it looks. You can see from the beginning SAPIEN and then XT SAPIEN 3 valve, and then the Ultra with the enhanced skirt. This is how the delivery system looks no longer. So we don't have to prep the valve in the body. So that will be a big advantage for the procedure. The sheath, still the 14 French expandable sheath, and the newer skirt with a textured and a taller skirt to prevent paravalvular leaks. And you can see that the paravalvular leaks continue to decrease. I think we really try to reduce this paravalvular leak to almost zero. I think patients really feel much better when there is no leak. So we can see that in the SAPIEN 3 Ultra registry, the moderate or severe paravalvular leak was only 0.5%. And again, the pacemaker rate is still as low, about, I think on average, about 5%. So I wrote this editorial about maybe 5 years ago now, where I know there's things I discussed and it's still relevant. I mentioned that the future of TAVI looks very bright. The balloon expandable SAPIEN platform produces excellent outcomes, improved, especially simplified technique for TAVI for the procedure, and better devices will continue to improve outcomes. Durability of the valve will become a key consideration. And Asia, and especially Southeast Asia, needs faster access to newer technologies and devices for the benefit of our patients. So thank you very much for your attention.
Well, thank you very much, Paul. That was an excellent presentation and gave us a very good summary of what has happened over the last 15 years or so in Southeast Asia, and certainly gives us a taster of what is to come to Southeast Asia in terms of TAVI technology. We will spend a few minutes asking the audience if there's any live question coming in, but maybe before that, let me ask you one burning question that I have for you, Paul. So if you were to summarize all the technology improvement in the last 15 years or so, what would you say the 2 or 3 most important improvement that happened in the last 15 years that really brought the technology to what it is today as a routine procedure?
Yes. So I think that the first, probably most important thing is that the sheath got smaller. So from 22 French, which means the outer diameter of nearly 8 mm, it became 18 and then now 14. So at 14 mm, I think we are reaching a comfortable zone. Although I wish it could go down to 10 or 12, and then maybe one day we don't really have to do all this. At 10 French, maybe one pro glide might be enough. So I think that alone has really changed the whole TAVI outlook. And the second thing I think that really has improved the outcomes would be the external skirt to seal the paravalvulics. I think that was one problem that we faced, especially in very calcified valves, bicuspid valves. It did not seal very well, and patients ended up with mild, moderate, and moderate paravalvulics. Didn't do so well. So I think these two features alone has revolutionized the whole approach to TAVI.
No, absolutely. I think you're absolutely right there. That I think Edwards Lifesciences led the way in both of this front, really, with the outer skirt and also reduction in the profile size of this valve. And also, I think not the technology evolution itself, but I suppose the pre-op assessment of this patient. I think CT analysis also was a big game changer from the early days where we had to use fluoroscopy to estimate or an echo to estimate the femoral size and the annular size. I think with the advent of CT imaging, I think that really cut down a lot of the complication rate for this technology as well. What do you think, Dr. Mann?
Oh, hi, Jimmy. Yeah, I agree with both of you. I think the key size is, for me also, is help us doing transfemoral more often with the good results. And I think that's the real reason. But of course, there's a multiple main reasons that help us can do TAVR more effectively and safely as well.
Yeah. Dr. Nguyen, is there any live questions from the audience at the moment?
Hello.
Hi.
Các bạn có câu hỏi nào không ạ? So I have one question. Do you think in our region, Southeast Asia region, is there any difference about the life expectancy or aortic anatomy that and the implications of that compared to the population that treated in Europe and North America countries?
So maybe Paul can take that question.
Oh.
I think yes. So I think first of all, our patients are smaller. I think many papers we've looked at this iliac anatomy is smaller, but you look at the Japanese publications, even our patients, the aortic roots are smaller, especially in females. So that's one difference that we have to be more careful sizing wise. So I think that's the major difference between us and them. And then, of course, the etiology of the aortic stenosis, we see a lot, especially in, I think, Vietnam and China, there are a lot more bicuspid valves and maybe even rheumatic problems. So, and we know that bicuspid valves, there are some special considerations that are quite different from the normal tricuspid anatomy. So this will be the main difference between Asia and Europe. But otherwise, I think results it's been quite good. I don't think there's a big difference in the results with the current devices between Asia or Europe.
And Dr. Mann, what about your experience in Thailand?
I think the question also addressed regarding to life expectancy. I mean, I think for our region, as compared to Europe and maybe, I'm not sure about Singapore, but in Thailand, I don't think our general population lives that long. I think that for men, it's probably mid-70s, and for women, maybe high 70s only, would not be as like 80 plus like in Europe. And that might give us some idea about I mean, I think the durability of the valve is still very important, but I'm not sure if our people will live that long like in Europe. So the cutoff for when we should do TAVI maybe can be considered a little differently in the region, I think.
Yes, of course. I think both of you have sort of summarized what's the situation in Asia, really. I suppose we are also, when we do TAVI in younger population and lower risk patients, we have to be mindful that we also have to prepare them for certain features that potentially can happen in their lifetime. For example, they may end up needing open heart surgery at an older age, whereas previously a lot of these patients would have had the surgery at a younger age. They may also have failed TAVR valve if they are able to live a bit longer by this technology. And also PCI, ischemic heart disease. We know that probably about 30% of patients with aortic stenosis potentially have coronary artery disease. They may already have PCI before, or they may develop ischemic heart disease moving on later on in the lifetime. So these are issues that I think have to be, we as TAVR technologists have to be mindful when we are seeing any individual patient to take these into consideration. And I think Paul and Dr. Mann has completely summarized the situation in Asia, that these are the main differences. And so, Paul, for bicuspid valve, what is your go-to, and to Dr. Mann as well, for bicuspid patients, which is a big chunk of Asian population, what is the go-to valve for you in your practice?
If there's any superiority between the two, I'm quite comfortable using the SAPIEN 3. I think for the last 5 or 6 bicuspid valves, I've used the SAPIEN 3 and I actually get very good sealing. In most of the patients, I have got almost trivial leak. Maybe 1 out of that 5 or 6, I got mild leak, but that's all I see. And I don't see any problem with the root risk of root rupture. I think if you size it correctly, and if you know exactly what the dimensions are on CT, you can always underfill or the balloon. So I'm quite comfortable with SAPIEN 3, to be honest.
How about Dr. Mann?
Yeah, me too. I actually share the same thought as Paul, in the sense that if you size it properly, the risk of rupture is very low or none, and also minimum leak, and also had a good gradient afterward as well. So I have no problem with SAPIEN in the bicuspid anatomy.
Perfect. And I can tell you from a surgeon's point of view, doing surgery to retrieve a TAVR valve, doing surgery on a patient who previously had a SAPIEN valve, where it's a very short valve stand and all you have to deal with is the annular area by pulling it out, and maybe none of the aorta is being interrupted. So doing surgery on a high, tall frame like a self-expanding platform is potentially more treacherous and may end up doing sending aorta replacement or root replacement. So I think I'm very happy to hear that many of you will be are actually SAPIEN users, especially in the younger patient who may in future needs open heart surgery. So maybe time is moving on. Maybe let's move on to our next speaker, Dr. Mann. Now, Dr. Mann again doesn't need much introduction really. Dr. Mann has been in this arena for many years. Dr. Mann was actually did his a residency in St. Paul's Hospital, British Columbia, in Vancouver. He did after his residency, he's board certified, and after his residency, he then did his fellowship in intervention cardiology and structural heart cardiology in St. Paul's Hospital, Vancouver. This is the place that I did my fellowship. But I think Dr. Mann left Vancouver just as I started my fellowship there. That was many years ago. And since then, Dr. Mann has come back to Thailand, and he's now an intervention cardiologist and structural heart cardiologist. He's the director of the heart center at his hospital in Ramadipati Hospital. He's very experienced in this technology. He's a scientific chair and director of many workshops and conferences, and he's very, very well published in this area, and he's well versed in many TAVR technology and has been on the podium speaking about this topic in many international scientific conferences. So without much further ado, let's invite Dr. Mann to share his screen and deliver his presentation today. Dr. Mann.
Oh. Thank you, Jimmy. Thanks for the kind introduction. And it's good to see you and Paul as well. So my talk today, they want me to talk about the versatility of the balloon expandable platform in non-native TAVR. Actually, Paul has mentioned some of it already, but I'll just share our experience. So basically, with the short platform, as Jimmy mentioned, balloon expandable, we actually can treat it in all 4 valves, aortic, mitral, pulmonic, and tricuspid. other than the aortic, the mitral and the tricuspid, we need some sort of ring or valve to dock the system. I'll share with you. This is our experience at Ramatipati Hospital. So we did all 4 valves, and I'll share with you one individually. But for today, we're going to skip the aortic one. For the mitral one, we have done about 5 cases, and the age is about 72. It is 3 cases of regurgitation and 2 cases of stenosis. Half of them are kind of in-hospital cases, so they presented quite ill with heart failure, and the length of stays is about 10 days. We have used all sorts of valves as shown here, but all 5 valves were SAPIEN 3. We use rapid pacing in all cases, and all transeptal access. We had good success with the results. We had one infective endocarditis afterwards, which being treated and now still doing good. No death, no heart block, no LVOT obstruction. There's 2 cases of some paravalvular leak, which later fixed properly, and there was no intravalvular regurgitation. All of these 5 valves are still alive and well. So I'm just going to share with you in terms of mitral valve and valve procedure what we have to prepare to do these cases. So I divided them up into how to screen the patient. So basically you need good echo images and CT. We need to know our bioprosthesis valve. Importantly, for the mitral position, we need to assess the risk of LVOT obstruction, and the step itself involves transeptal and how to do it properly. Positioning the valve is important, and assessment of iatrogenic ASD afterwards. So as mentioned, CT and echo work harmoniously. We need both, and each tell us a little differently in terms of what we need to look at. The valve, what valve was the previous bioprosthesis valve, also important. The important part for the valve is the internal, true internal diameter of the valve, so that we can decide which SAPIEN valve we're going to use. Also, not only that, we also need to look at the angle between the aorta, the aortic valve, and the mitral valve, and also the depth of implantation. As you see here, the angle, the more parallel to the mitral and the aortic, the better. If it's the mitral is point towards LVOT, then there's definitely higher risk of LVOT obstruction. This is the LVOT we called neo-LVOT, which is one of the main concerns of valve in the mitral position. So the neo-LVOT estimate should be at least more than 170, or in real life we use about more than 200 square millimeters. If not, then there's increased risk of LVOT obstruction afterward, which is something we want to avoid. So this is an example of a case we did. It's a 74-year-old man with IE in the mitral valve, underwent magna valve in the mitral position, and also tricuspid position as well. Interestingly, the mitral valve failed first. So we brought the patient back. Before that, we did the assessment. You can see that we need to measure the neo-LVOT, and in this area is 400, so it's plenty of room. I found that the LVOT obstruction is much less concern if it's valve in valve, but if in valve in ring could be dangerous. So you can see we can do transeptal, deploy the valve properly, and that's afterwards. So it's actually pretty step-by-step procedures, and very come with the good results. Another more challenging case is another valve in ring case. So we use this valve in valve apps, and we need to know what kind of ring it is. We need to know the area, but the challenging is that the ring is usually not round. So it needs to be semi-rigid ring, and preferably complete ring if possible. And then we can decide which valve we're going to use. This is a sample, so we have to go through the same process of CT assessment of neo-LVOT estimates. And we need to look at the angle, as we mentioned, and also with the new pre-planning procedure, we even can tell where to puncture the septum. So this is a case of valve in ring in the mitral position. That supports dilatation, and that's the final results. In the pulmonic position, we also did a few, could be bioprocesses, could be conduit, could be even native. And so if you go into the pulmonic position, you need to understand a little bit more about the adult congenital heart disease of the anomalies of the alveoli, which could range from tetralogy Fallot, truncus arteriosus, TGA, and others. And the previous surgery that they had before, whether it's a conduit or a valve replacement or a native alveoli. And we know that all these valve and conduit gonna fail at one point, so there's a need for redo procedures. And transcatheter TPVI is considered one of the treatment option, and now for ESC, it's even a class 1 indication. So this is a sample of 37 years old woman, man who had, we had a lot of endocarditis, as you see, VSD with infective endocarditis that the patient underwent mitral, pulmonic, and tricuspid valve surgery, now presented with a failure of tricuspid and pulmonic. So we can fix both valves with valve-in-valve procedure using the SAPIEN. We usually fix the distal valve first, so you can see that we fix both pulmonic and tricuspid all together using a SAPIEN, I think 26 and then 29 in the pulmonic and tricuspid respectively. Another challenging case that we could also do SAPIEN in is the native alveoli. This patient had tetralogy Fallot with total correction at 6 months old, now presented with severe RV dilatation, but still preserved function, severe pulmonic regurgitation, estimate regurgitation fraction almost 50%. So we can also stuck the SAPIEN valve into this native alveoli, but you need balloon testing and a little bit more details about it. But I just want to show that it can be done, and we have done this successfully in many cases. For the pulmonic position, just to get the flavor of it, you need to assess the coronary obstruction with the balloon testing to make sure there's no aortic compression or coronary compression. Like in this case, you can see there's a compromise on the aortic position, or it can also compromise on the coronary side of things. You can see that with the balloon testing, it compressed the proximal RAD. So we find this procedure cannot be done. So this is something to look for if you want to do pulmonic position. But if none of these happen with the testing, we can go ahead and fixing it with the SAPIEN valve. Now with the tricuspid valve, we also have some recent publication. Now we did 6 cases. And this is also interesting part because the range of ages in our series is between 25 to 77. Both can be regurgitation or stenotic failure, and length of stay afterwards is minimum. So it could be Epstein anomaly, straddle tricuspid valve, like a complex congenital heart, history of chest wall trauma that underwent tricuspid valve replacement before, infective endocarditis, or even in some rheumatic heart disease. So we had put in mainly either 26 or 29 in the tricuspid position, not necessarily need rapid pacing for these, or success with no complication. I just want to show you this is a complex congenital heart disease, 24 years old with straddle tricuspid valve, double inlet RV, a small mitral valve, valvular PS, D-related great vessel, ASD and VSD, had multiple comorbidities. Now present with tricuspid valve replacement failure that was a Magnum 29. So the adult congenital team wanted us to fix the tricuspid valve. This is the echo to show that the valve is really obstructed with the gradient of the relatively high gradient, and we deploy the tricuspid valve as shown here. This is a little unusual tricuspid valve position. That's why the angle looks a little odd, but afterwards it had good results. Tricuspid valve in ring also can be done. We did it. This case is underwent mitral valve repair. And also tricuspid valve repair. They use a contour 3D 28 mm earlier, but the procedure didn't go well. The patient went into torrential TR post tricuspid valve repair. This is the procedure beforehand. You can see RVSP was 62. So we assessed the ring, a little challenging. This is the contour 3D number 28. You can see that it's not a complete ring like the mitral position. This non-ring area usually just to reduce the risk of AV block afterwards. Very oval looking, minimum of 19 and maximum of 28 with area 449. We did a balloon testing. We want to make sure when we do the ring to make sure that the new valve going to stay in the ring, not outside the ring. So that's how we do it. When we deploy the valve, we usually do two orthogonal view to make sure that the valve will be deployed within the ring, not in the non-ring area. So that's afterwards. You can see there's a significant leak later on, which in this case, I think we'll plan to do a plug later on. But with the leak agitation, it will reduce from severe TR to mild to moderate TR only. So just for the interest of time, I just want to share that with the balloon expandable platform, we can do a lot of things that can help our patient in non-native AS. We can do RVOT, either conduit, native, or hybrid. For bioprosthesis valve failure in the valve position or ring position, we can do it in aortic, pulmonic, mitral, or tricuspid. So this procedure kind of open new option for surgical valve selection in patients that require surgical replacement in young age, including left side. Thank you.
Thank you very much, Dr. Man. That was extremely well presented a talk, and it makes us all very jealous because you are playing with a lot of different pathology. In the interest of time, maybe I will kick off with my presentation, and then we could take questions all together at the very end. So let me share my slide. Share screen, and this one. You can see my screen?
Yes, we can see it.
Perfect, great. So thank you very much for having me again. My name is Jimmy Hon, and I'm a cardiac surgeon from National University Hospital in Singapore. I'm also the surgical lead in the TAVR program there. These are my disclosures. So in terms of durability, there's really no real alarm bells for any TAVR technology, be it self-expanding or balloon expandable. So SAPIEN 3 is the latest generation, third generation TAVR valve from Edwards Lifesciences, and definitely SAPIEN 3, we all know, is the market leader internationally, and it's also the main workhorse for most centers around the world. And so what do we know about the SAPIEN 3 TAVR durability so far, specifically? So to look at that, we look at two studies. First, we look at the 2-year results from the partner 3 low-risk trial. We heard from Paul earlier that this is the low-risk trial looking at patient STS4 4 or lower, STS4 4 or lower, and the 2-year results were published just under 1.5 years ago. Just very briefly, death, stroke, rehab, hospitalization shows superiority in the TAVR arm versus the surgery arm. And in terms of valve performance over the 2 years follow-up period, you can see that the mean gradient has improved significantly after implantation of both TAVR and surgery. And the aortic valve area improved with TAVR and surgery. And this improvement lasted over the 2-year follow-up period. The paravalvular leak, of course, we all know that surgery does make better because you actually stitch the valve in. But nonetheless, the TAVR results are very impressive. most patients had trace or none, with only about a quarter of patients had mild. Very, very few patients had mild, moderate, and almost no patient had moderate severe in the study period, and this is consistent over the 2-year period. If we look at hemodynamic valve deterioration and prosthetic valve failure, the numbers are very low at 2 years. For stage 2 and 3 hemodynamic valve deterioration, the number for TAVI is 1.45% and 0.71% for surgery group, and prosthetic valve failure is even lower at 0.41% for TAVI group. At that time, at 2 years follow-up period, there's no difference between the two groups of patients between surgery and TAVI. So that's using SAPIEN 3. So SAPIEN 3, low risk category patients, no problem with durability at 2 years. So now we move on to look at a longer term follow-up. To look at that, we seek some insight from the intermediate risk patient, which is STS score 4 to 10. This is partner 2 trial. Most partner 2 trials were done using SAPIEN XT, but there is a cohort that is a SAPIEN 3 cohort in this partner 3, and they analyze this cohort using propensity match analysis, and we get insight for durability with the 5-year outcome. As you can see from this graph, that at 5 years, there's no difference between surgery and TAVI using SAPIEN 3 at 5 years. These are all 5-year results, and disabling stroke noted no big difference between the two groups, except that p-value is 0.05 with the advantage towards TAVI. The mean gradient over 5 years were low after implantation of surgery or TAVI, and that improvement in mean gradient sustained throughout the 5-year follow-up period, and so did paravalvular regurgitation data. So as you can see, after treatment, most patients in the TAVI group had none or trace, with about a third had mild, and over the 5-year period, follow-up period, that actually improved, with the mild proportion down to less than about a quarter, and most patients still had none or trace. Very, very few, almost no patient had severe paravalvular leak. So these are impressive data at 5 years. So moving on to look at hemodynamic valve deterioration and prosthetic valve failure, the numbers again at 5 years are very, very low. For stage 2 and 3 hemodynamic valve deterioration, the number for TAVI, SAPIEN 3 was 0.63 compared to 0.6 in the surgery arm. No difference between the two groups, and these are low numbers. And similarly for prosthetic valve failure, these are also low numbers with no difference between the two groups with TAVI and surgery. So impressive data. This is interesting. If you look at this particular results for the same cohort of patients, surgery and SAPIEN 3 were very similar in terms of structural valve degeneration. So SAPIEN XT seems to divert a bit and became significant difference between SAPIEN XT and SAPIEN 3 and surgery. So perhaps SAPIEN XT did not perform as well as SAPIEN 3. As we said, SAPIEN 3 is now the worldwide leader and is also the workhorse now. So we are talking about. So stable gradient over 1 to 5 years for SAPIEN 3, low rates of structural valve degeneration, and paravalvular leak rate are very low in both therapies. So no worries absolutely with durability so far with SAPIEN 3 valve. So we've heard how versatile SAPIEN 3 is. So this is just a reminder of how versatile SAPIEN 3 is. We have heard anecdotal reporting from Dr. Paul and also Dr. Mann, individuals case reporting. And this is really to understand why it's so versatile. We really need to go down to look at the delivery system and also the valve design itself. So just very quickly run through the SAPIEN transfemoral commander delivery system. You can see the nose cone is pointed enough and soft enough to be safe and easily enable us to cross the aortic valve easily. There's a marker that easily allows us to position the valve. That's very visible on the X-ray, so we can position the valve in a very easy fashion and safe fashion. The balloon is robust and stable and gives a predictable deployment. We have never had any problem with this balloon at all, no balloon rupture at all in the last 12 years that we've used. This is a this flex cath is smooth, it's 14 French issue compatible, and it's very flexible. Particularly the distal 1/3 is flexible using the flex view, which is shown here, to flex the distal third of the catheter, as you will see in the next few slides. The fine adjustment view is also a game changer. It allows us to adjust the position of the valve at the annulus in very, very small movements rather than pushing and pulling the whole device, which will create macro movement. So the fine wheel adjustment allows us to accurately position the valve at the annulus. Now there's the balloon lock, the flush port, and balloon inflation port. They are standard. So you can see from this diagram that with the flexible catheter and the flexibility of the distal third of the catheter, you can negotiate the aorta, and most of these old people's aorta are very dirty arterial matters. So this is absolutely a game changer, an important characteristic of this delivery system that prevent us from scraping dirty aorta. And you can see that especially for horizontal aorta, the ability to flex the distal third of aorta of the delivery catheter enable this system to deploy the valve in a very coaxial manner rather than the self-expanding platform. As you know, self-expanding platform, there's a push towards the outer curve because it's not flexible. It's pre-flexed, and hence, as a result, a lot of times for horizontal aorta, you may deploy the valve in a one side deep, one side shallow kind of position, and it's less predictable. And also when you remove the nose cone, the self-expanding platform may just press on the outer curve and interact with the TAVR valve, and then with this flexible SAPIEN delivery system, you are able to lift the nose cone off the valve and retrieve the delivery system in a very safe manner. So this is just a picture to show you how predictable delivery can be. So we wanted to end at a thick red line, and we were able to achieve that fairly easily. And this is the end result. Pretty nice implant. So SAPIEN valve design, as you all know, is cobalt chromium. It's a low frame height, hence interference with coronary ostium, and also for future surgery, it's a lot safer and a lot easier. There's a large wide open cell up top, which allows coronary access much easier. And also it's a 14 French shift compatible device, a very small profile device. And also looking at the commercial attachment leaflet. This is just one little small device to attach to the commercial of the leaflet, unlike self-expanding platform whereby your covered cell extends all the way up to the top of the commercial, potentially covering your cells and impeding coronary access in future. Tissue is bovine pericardium, same tissue as the very robust perimal magna valve, as we know, with a very good durability. Outer skirt, that's game changer. We've heard that before. The PET outer skirt reduced power verbally since its introduction. Now, there are 4 valve sizes, 20 to 29, 20, 23, 26, and 29 millimeter. And with these 4 valve sizes, we are able to treat 98 to 99% of aortic stenotic cases in our institution. So absolutely wide annulus range cover. Coronary access. In the last few years, there's been a lot of talk about coronary access. Why? Because we are treating lower risk patients and potentially younger patients. So coronary access becomes a very important issue. A third of patients has coronary artery disease, and these patients may develop ischemic heart disease in future, and hence there have been a lot of concern about that. And using a low frame height valve like SAPIEN valve with big open cells, coronary access and PCI becomes a lot easier. And there, as I said, there have been a lot of publication and concern about this area in the literature, and particularly concerns about using self-expanding platform whereby the supraannular valve sits high with a large covered cell area, making PCI sometimes impossible and with catastrophic results in this situation. Versatility, we can use this in bicuspid aortic valve stenosis. So we've heard some case reporting, single case reporting earlier. Just to show you the sort of cohort results, we can get some insight of bicuspid performance treated by SAPIEN 3 in their partner 3 bicuspid registry. You can see that the 30-day mortality, primary endpoint 6.8% versus 4.7%. There's no difference between the two groups. No death and similar stroke rate. So there's really no difference between bicuspid and tricuspid use of SAPIEN 3. Echo findings, the mean gradients improve and the affected orifice area also enlarged after treatment, and there's no difference between the bicuspid TAVI or tricuspid TAVI. Paravalvular leak, again, very similar between the bicuspid aortic stenosis and tricuspid aortic stenosis using SAPIEN 3 treatment strategy. Patient improved, and most patients after treatment were in NYHA 1 and 2, with very, very few patients in 3 and 4, similar to bicuspid and tricuspid group of patients. We also heard that aortic valve-in-valve is also a capability of SAPIEN 3 valve, and this was first reported in 2010, long time ago. This is a case that we did a few years ago now, implanting a TAVI valve, a SAPIEN 3 in a Percival valve. Again, a very predictable deployment and giving you very predictable results. Looking at cohort data, we know that valve-in-valve treatment reduced the 30-day mortality from open heart surgery rate of 7.3 to 3.6 in this rather large cohort study. And the 5-year results from the partner 2. Now, I have to say that this partner 2 valve-in-valve registry uses SAPIEN XT, but nonetheless, it gives you a taster of what SAPIEN 3 could do. There's improvement in mean gradient, and that mean gradient improvement improved over the 5-year period, sustained over the 5-year period. And the total aortic regurgitation, again, most patients had mild or none or trace. Very, very few patients had anything more than moderate or severe. And the results persisted over a 5-year period. Similarly, all patients improved after valve implantation with the XT valve. And you can see from this graph that structural valve degeneration related hemodynamic valve deterioration were very low at 5 years, 5.9%, with biprosthetic valve failure rate of only 4.7% at 5 years. Half of them were structural valve deterioration related, SVD related, the other half probably due to endocarditis. So very low rate of valve issue at 5 years. It shows you that valve-in-valve results are very similar to the native TAVI using XT valve for structural valve SVD related failure or all biprosthetic valve failure. They're very similar. And we saw earlier that perhaps SAPIEN 3 results are superior to native TAVI using XT valve. So we are very hopeful that this will continue to improve using SAPIEN 3 valve. So lastly, we talk about mitral valve-in-valve, and sorry, the valve, the cine is not running, but this is the case that we did transeptally mitral valve-in-valve. And we know that redo mitral valve surgery is a very high-risk, high-morbidity operation. 30-day mortality, most series reported above 10%, or more in the between 11 to 15% kind of region. The more operations you do on one particular patient, the higher the surgical risk. And just to show you specifically SAPIEN 3 results in mitral valve-in-valve, we look at this 1-year outcome. If you just look at the transeptal results, the technical success rate is high, 97.1% successful implantation using the transeptal route. The 30-day mortality is low. And you can see that 30-day mortality is all-cause mortality is 5% versus above 10% that we saw earlier, and cardiovascular death is only 2.1% at 30 days. The mean valve gradient reduced after mitral valve implantation at 30 days, and that lasted at 1 year. Most cases now, you can see from this graph, has moved over to transvenous transeptal mitral valve and valve implantation nowadays. And if you split this registry using the year, you'll see that since its introduction of this registry in 2015, the mortality for this mitral valve and valve procedure has dropped year on year, making it a safer procedure as we learn more. FDA, as you heard earlier, FDA approved this technology for mitral valve and valve for high-risk patients in 2017. So valve and valve is associated with high technical success, with low complication rate and 30-day mortality, much lower than the predicted risk score by SDS score. And valve now has the potential of allowing patients to continue enjoying the many advantages of tissue valve without the need to undergo high-risk redo open heart surgery. So I hope, ladies and gentlemen, you'll be convinced after hearing all three of us that SAPIEN is a really extremely versatile valve. It gives a predictable deployment. It covers a large annular sizes. It gives you preservation of coronary access. It also allows you to use SAPIEN 3 in bicuspid valve pathology, aortic valve and valve, mitral valve and valve, and you heard earlier from our previous speaker, tricuspid valve and valve and ring, and also congenital cases. With that, I think I'll stop here, and we'll be happy to, all three of us will be happy to take questions. Are there any questions from the audience, the panel?
Đồng nghiệp chúng ta có câu hỏi gì không ạ? So Dr. Han, we have a few questions here.
Yeah.
What do you think about the definition of structural valve deterioration, and what the implications of that in the trials of the durability of transcatheter heart valve?
So I think maybe Paul and Man will jump in. So I think that's a good thing. That I think it's a fair definition. It sort of normalize and put both surgery and TAVI on an equal benchmark to assess each other's durability and performance. So I think the structural valve degeneration currently is classified, the valve 3 classified into grade 1, 2, 3, and valve failure, prosthetic valve failure is defined as severe grade 3 or further intervention. So I think that sort of set the platform for comparison for all the trials. Whereas previously in surgical assessment, surgical valve assessment, we really look at re-intervention, and that sort of missed out a lot of the valve failure that we were seeing nowadays. And now with this common definition, I think it uncovers that actually surgical valve does have some hemodynamic valve deterioration as well. I don't know what Dr. Paul and Dr. Mann thinks.
Do we have any data on the increase of transvalvular gradient of the partner 3 at 5 years for the balloon expandable valve? Because we have this data for the self-expandable platform.
I'm not aware of 5-year data for partner 3. Paul and Man, maybe you can take this as well.
Yeah, I could share a few thoughts. So with the valvular design of the balloon expandable platform, there tends to be higher gradient and low EOA after TAVR as compared to self-expandable. But the degree of the gradient that it went up, usually the definition in VAC criteria, I think they use in general more than 20 mean gradient above. And certainly there will be a little more of the balloon expandable TAVR compared to self-expandable or supraannular design. But with that, I think we need to estimate with caution, because there's a few factors that affect that. When you look at the mean gradient alone, it really depends on the echo gradient, and we know that there's a pitfall in measuring echo gradient in a different kind of platform of the TAVI valve. But as far as I know now, in the long run, at least up to 10 years, maybe not randomized data, but it did not show that balloon expandable platform fails early, or there's a higher rate of reintervention higher, or as a matter of fact, not all data, there's no firm data to show that it had worse durability compared to self-expandable platform, in particular the heart endpoints. But definitely the gradient, when you measure by echo, it will be higher, no doubt.
Thank you, Dr. Mann, and thank you also for your excellent presentation. So I have a question for you. You mentioned about paravalve leak. So what the mechanism that mitral valve can address paravalve leak?
Actually, paravalve leak in the mitral valve-in-valve position is pretty rare. The reason is because we know the exact size of the bioprocesses, the internal diameter, and as long as we properly size the valve. But when we do this, it's important to deploy the valve in the proper position. If you deploy it too proximal or distal to the anchor point, then that's where the leaks can occur. But in general, valve-in-valve position, either mitral or tricuspid, it's pretty rare if you do it properly. Whereas when you do it in a ring, either mitral or tricuspid, it's more challenging because the ring is not round. So you need to make it as round as possible. And that minor leak can cause a severe problem, because in the mitral position, the left ventricle and the left atrial pressure gradient is high. So the risk of hemolysis is very high. Whereas the tricuspid case I show you, there's still residual TR, but there's no hemolysis, and that's not a big problem. We can come back and plug it with the vascular plug later on, or we can even leave it. But I think for the mitral in ring, you need to be really careful about residual PVL. Yeah, I'm not sure what Paul and Jimmy think. That's my thought.
Yeah, we have not done any valve in ring at the moment. We've done valve in valve in the mitral position through the transeptal route, and those are pretty straightforward cases. Really, transeptal is a very doable procedure, and especially there's a Vini Papat app, and there are videos in there. You literally the positioning of the valve is just follow Vini, and you get it in the right position. And one of the main reasons why you can get in a good position in most cases, in almost all cases, is because this delivery system gives you such predictable delivery of the valve. So it's not a problem. And you're right. A valve in ring in your presentation is a much more challenging procedure. From the registry, you can see that valve in ring mortality is still in the double digits. So I think Paul's probably got some experience in valve in ring as well. So Paul, maybe you can tell us a bit more about valve in ring procedure in the mitral position.
Not only the valve in valve, we haven't had any valve in ring. But again, we see almost no paravalvular leak with the valve in valve if you size it correctly. So I don't think paravalvular leak is an issue with the valve in valve procedure.
So after discussing all the cases, all the wonderful cases that Dr. Mann and Dr. Paul has shown us, balloon expandable platform is a technology that every TAVI program must have, because this is the go-to technology. That with this technology you are able to treat a wide variety of cases, not just valve-in-valve cases, many of the congenital cases, and also the mitral side of pathology as well. So, but yes, all things said, I think any program should have a balloon expandable technology and also a self-expanding technology. But I think the versatility of the PHImôN platform is second to none, really. Any other question from the floor? So maybe I'll just throw in one last question. Now, this technology is very mature, and now it's a routine technology in TAVR treatment. So to Paul and Man, in your mind, is there any other unmet needs for aortic stenosis in Asia that you can think of to improve this technology further to make it even better, specifically for Asian patients? You're muted. Paul, you're muted. Yeah, okay, you're back.
Can you get me now?
Yeah, you can hear me.
So maybe for me, the sheet could become a bit smaller still. That would be very, very nice. I think that would be, and of course, the cost must come down.
Yes. Dr. Mann?
Yes, agree. I think the cost for me is the main issue. In Thailand, we still not reimbursable despite all these cases we did. So that will help a lot. And perhaps if I can think of, maybe I found a lot of a good portion of the patient had very small annulus, and perhaps they can decide certain valve that can handle this smaller annulus than it is. But I think the cost is the main thing if I have to pick one.
Okay, so I think Edwards Lifesciences is here listening to this. But nevertheless, I think this is a very important lunchtime symposium, and it's a very timely one. It's a 20-year TAVR journey, and I thank our speakers, Dr. Mann, Dr. Paul, and Dr. Nguyen, and also I thank the audience for taking time to attend this lunchtime symposium, and of course Edwards Lifesciences for taking the initiative to educate us by having this symposium. So I hope everyone is having a great rest of the Congress, and we really hope to meet everyone in person very, very soon. So I think time is moving on. We'll close this session. And thanks again for attending.
Okay, thank you.
Thank you, the panelists, to join us, and thank you all the participants. Yeah, we close this session.
Thank you very much.
Thank you.